Good morning and welcome to the ASMBS Fellows Project. Welcome to our friends from the East Coast, the West Coast, and around the world. We are really excited today. We have some fantastic lectures on bariatric bypasses. One housekeeping note, don't forget about the Bariatric Fellows Happy Hour that is normally the fourth Thursday of the month at 8 o'clock. You can register on the ASMBS website. We've had really good attendance, so I know a lot of you already are registered. One note that this month it's going to be on the 17th, as the 24th, which is the fourth Thursday, would be Thanksgiving. So November 17th at 8 o'clock, you can register on the ASMBS website. Back to today, we have two phenomenal speakers. We'll start with Dr. Helmuth Billy, who will be speaking about one anastomosis gastric bypass. Dr. Billy has been in private practice bariatric surgery since 2000. He's located in Ventura, California, where he serves as teaching faculty in the Department of Graduate Surgical Education. He has taught fellows and residents both nationally and internationally and has lectured extensively over the past 20 years. He is currently the president of the California chapter of the ASMBS and is a member of the ASMBS Executive Council. His current area of interest and research focuses on magnetic anastomosis in bariatric surgery and the use of sleeve gastrectomy for the treatment of gastric paresis. He has authored textbook chapters on the subject of bariatric surgery and OAGB and has published multiple papers in the medical literature. In his spare time, he enjoys skiing and spending time with his family. Our second speaker today is Dr. John Rodriguez, who is coming to us from Abu Dhabi. He is the chair of surgery within the Digestive Diseases Institute at Cleveland Clinic, Abu Dhabi. And his specialty interests include minimally invasive gastrointestinal surgery, surgical endoscopy, bariatric surgery, and robotic surgery. He has co-authored many articles and book chapters that have been published in leading medical journals and has participated in multiple national meetings. Some of his areas of research interest include revisional bariatric surgery, minimally invasive abdominal wall reconstruction, surgical and endoscopic management of gastroparesis, among other topics. Dr. Rodriguez actively participates in community outreach programs for underserved Hispanic populations in the Cleveland area. He is fluent in both English and Spanish and will be talking with us today about Roux-en-Y gastric bypass. So Dr. Billy, I will hand it over. I think you're still muted.
Sorry. Yes, the mute button. First, let me say thank you to the ASMBS and to Duke University for the invitation. This is one of the things I enjoy most. These webinars have turned out to be quite a rewarding experience for all of us and have improved our ability as an international community to keep these topics going. So let me see. Here we are. All right. Have I successfully got my first slide up there?
You have. That looks great. Thank you.
Okay, so I apologize for that. That's also the limitations of my age. Today, here are my disclosures that are always required. And I just want to touch quickly on the historical review of OAGB. This could be a lecture all on itself, but the story really begins in 2001 when an interesting new paper popped out from a surgeon named Robert Rutledge, which everyone interested in OAGB and even not interested in it often recognizes his name. He published a paper on 1,200 cases, his own personal experience with an operation he called the mini gastric bypass. And that really launched the first discussion of the use of a loop gastric bypass instead of a conventional Roux or two anastomosis bypass for the treatment of obesity. And this is the original illustration that he used in his paper. It's hand drawn. He described a simplified version of what was a traditional Roux, and his whole purpose was avoiding the creation of a small gastric pouch, which is typical with the Roux, and creating a larger pouch and avoiding what he described as permanent gastric restriction. It eliminated the second distal anastomosis, and there were some benefits to that in terms of complications, which are required for a Roux bypass. The pouch he described was rather long. It was between 10 and 15 centimeters, which seemed gigantic to traditional bypass surgeons. And there was a single end-to-side anastomosis, which completed his operation. He described the benefit of it being able to be done quickly and efficiently, and his outcomes that he published were acceptable. For about 4 years, there were limited papers being published with the experience here and there. Large number of them were authored by Dr. Rutledge. And then out of Spain, Miguel Carbajo described an alternative technique using a single anastomosis, and he called it a one anastomosis gastric bypass. And he described a much smaller series, his first 200 patients. And one of the problems which had been becoming more increasingly described was an issue of was bile refluxing into the stomach, something that we should be concerned with. And his technique described a side-by-side anastomosis, which he coined one anastomosis gastric bypass. And the debate on what to name this persisted for another 15 years before both IFSO and the ASMBS chose to go in one direction and adopted the term one anastomosis gastric bypass. Dr. Carbajo described a long side-by-side suture, which would in effect create a situation where the afferent limb would literally trickle the bile past the anastomosis, hopefully decreasing the degree of reflux that would be described. And like I said, this went on with multiple papers, a few randomized controlled trials, but most of them were retrospective, some prospective studies on outcomes and series of individual authors that built up in the medical community to quite a large number until in 2018, IFSO published their first review and position statement on mini gastric bypass, and we'll get to that a little bit later, followed by a second position statement in 2020 to 2021, and there's soon to be a position statement published by the ASMBS after its adoption and endorsement of the operation as acceptable in earlier this year, around May or March 2022, the ASMBS had a position. But the actual procedure now comes down to two different techniques which have evolved as the standard approach that various surgeons utilize. The approach on the left here is Dr. Rutledge's end-to-side technique. And I'll show you some surgical footage, but really what it is, it's a long gastric pouch. The cartoons there show some vasculature, which is representative of the crow's foot. And you really want to stay at or below the crow's foot to create at least a 12 centimeter to 15 centimeter gastric tube. And then he does an end to side, which is either stapled or hand sewn. And on the right side is the Carbajo technique of the side-to-side anastomosis. Again, both anastomoses resulting in a connection that is at or below the crow's foot. Our operative approach is now 4 trocars with some internal liver retraction. We use 12 at the umbilicus, 2 5s in the left upper quadrant, and a 12 in the right upper quadrant. And techniques can evolve with various numbers of trocars. The hallmark of the operation is to really identify the crow's foot. And for the beginner or the surgeon doing this for the first time, there's a great temptation to try to cheat to get above the crow's foot because positioning that first stapler is rather easy. And those are the mistakes that are made when you try to reinvent an operation that's been done thousands of times by other surgeons, all of whom develop the philosophy that staying below the crow's foot and lengthening the pouch is somewhat the key to success with this operation. So if you remember one thing about this talk, remember that you got to go below the crow's foot and don't start trying to reinvent something we've all experienced as problematic if you start to cheat and go above the crow's foot. Then there's simply a 40 French or even larger bougie that you can use. There's no reason to keep this as tight as we might for a sleeve. And you traverse along the line there that's dotted and dashed towards the angle of his to create your pouch. The dissection is rather straightforward. Another visualization in a different patient, you can see the crow's foot. And then ultimately we're going in the direction of hopefully making our anastomosis just below the crow's foot in either an end to side or a side to side technique. And that's the basics of how this operation really moves. It's quite reproducible and it's quite easy to standardize, far more standardizable than what we have accomplished with Roux-en-Y gastric bypass. The afferent loop is measured between 150 and 200 centimeters. And then at the end of the procedure, you want to take the time to measure your common channel to actually see if you have at least 400 centimeters of common channel to avoid any of the rare complications which might surround nutrition and nutritional deficits. The final step in the procedure is to close the mesenteric defect. Many authors have not, but if you take the time to close the defect, it's rather easy. And it virtually eliminates the one location where you might encounter an internal hernia. I have not yet seen an internal hernia on our series. It is described, but it's very rare because the majority of surgeons will take the time to close this. And then you have your completed operation in the lower right, which is a in my case, a side-to-side anastomosis. This easily could have been a end-to-side. You can hand sew this in 2 layers. You can hand sew it with 4 layers. You can use stapled. There's many techniques to do this, and they all virtually end up looking almost identical when we're completed. I just want to take a little video to show you live, identifying the pylorus and the crow's foot. You'll hear this over and over again to get your point of dissection identified, which is just below the crow's foot, in between that and the pylorus. And I generally use a 60 black cartridge here, and the key is this is the thickest part of the antrum. And learning how to position your stapler is probably the most difficult part of the learning curve in this operation. You also have to be mindful that you don't go all the way across and amputate the antrum because that will cause a problem as you try to figure out what to do now. We use a 40 French bougie and we go along this line, which is imaginary in our mind. The bougie is our guide and we don't hug it. Here's the crow's foot. You can see that we're just below it. And once we transition from black to purple or whatever your favorite stapling company is, we then continue usually using the equivalent of a blue. Depending what company we use, we might use a purple cartridge. Then once we have separated through the angle of His, we then measure using a reproducible way of measurement, 150 to 200 centimeters. In the side-by-side technique described by the Spanish team of authors, we use a running suture. Here we're using V-lock. You could easily use Vicryl or PDS and create a long side-by-side tension-free anastomosis. Once that's completed, you simply open up the pouch and you open up the jejunal loop you've brought up. Here we're holding the afferent proximal portion. The bile will trickle past there as we create our anastomosis. And you can see this is a very time-efficient, straightforward operation with really a few limited reproducible steps. Once the stapler is fired, we advance the bougie, in this case a 40 French, across the anastomosis. We close the gastrojejunectomy with 2 layers and then proceed to close our mesenteric defect. When we're completed, I usually do an ICG study because I love ICG, and we confirm there's no leak, and then the operation is finished, and then that's the final format that you see there. So the historical papers that have all accumulated since 2001 really start to show a pattern of conclusions. Now, there are not that many randomized controlled trials, but there are enough that we can legitimately see what the outcomes are in that setting. But most of them historically are not. Dr. Lee in Taiwan has published one of the randomized controlled trials, and then another more recent trial was the Yomega trial out of France, which caused a little bit of controversy with respect to complications, but outcomes were the same as every other paper has published. The 2012 paper that was published with a 10-year experience by Dr. Lee concluded that the OAGB can be regarded as a simpler and safer alternative to laparoscopic Roux gastric bypass with similar efficacy at a 10-year experience. And that's really what we're looking for here, is what are the outcomes. His randomized controlled trial published 2 years data, and he had 80 patients, so it's not a big study. He used a consistent 200 centimeter afferent limb, and his conclusions were that both laparoscopic Roux gastric bypass and OAGB were effective for morbid obesity, with similar results for resolution of metabolic syndrome and improved quality of life. The OAGB was felt again to be simpler and safer in terms of complications, but had no disadvantage compared to Roux gastric bypass at the point of 2 years follow-up. Now here's some more of his data from his 2012 paper with 10 years outcome, and OAGB versus Roux, again, simpler and safer with similar efficacy, and feeling it was an acceptable alternative to the standard traditional Roux gastric bypass, which now then would give us other options and opportunities in order to produce our best options for our patients, depending on difficulty of surgery and anticipated outcome. So here you see the Roux gastric bypass versus the OAGB. And as far as early complications, they're broken into major and minor, and you see about a 5% major complication rate and a 15% minor complication rate. The OAGB had early postoperative minor complications that were a little bit higher at twice the rate of the Roux gastric bypass at twice the rate of the mini bypass. So the OAGB procedure seems somewhat safer in the early postoperative phase. Late complications were virtually identical. and had to do with readmissions and observations in this series. Dr. Lee also published a 15-year outcome in surgical endoscopy. This appeared in 2018, and it encompassed 1,700 patients who underwent OAGB from his beginning of the procedure in 2001 to December 2015. And the conclusions were, again, that it's an effective procedure for the treatment of morbid obesity and metabolic disorders, and resulted in sustained weight loss and a high resolution of comorbidities. And this is what you see over and over and over in these papers. I really chose Dr. Lee's papers because they're very well done and very consistent, and really are representative of a long-term experience. He also found that the OAGB had a higher weight loss on the average at 2 to 6 years than Roux-en-Y gastric bypass. And here's the long-term outcome curve. And you can see he starts out with 1,100 sleeves, 1,700 OAGBs, and 800 Roux, and they stay very close, but the blue line represents the OAGB. And it really outperforms all the other procedures that he was also doing at 10 years. And it becomes rather equivalent with bypass by the time you get to 15 years. But these are rather small numbers where sometimes you only have 19 to 20 bypass patients once you pass the 10-year mark. And I'm sure he's continuing to accumulate his data. And this becomes useful for all of us to see where the outcomes really go and what these retrospective or prospective but not randomized studies show us. Here we see the patient characters and perioperative outcomes, and he described complications as major and minor, grade 1 through grade 3 in the minor, and grade 3 to grade 5 in the major. The major complication rate is less than 2% in both Roux-en-Y gastric bypass and OAGB. So it becomes the early complications which are the more significant and more likely to be treated, but are not of relative danger to the patient or bad outcomes. A retrospective study here out of the UK, which was rather interesting because it had a large volume of patients, was over 500. And in the primary cases, which was the vast majority, they reported 519. And most of the cases that I did in the United States, as I learned how to do this over the last 5 to 7 years, were revision operations due to the limitations on insurance and the limitations with which the MBSA QIP put us under regarding IRBs and other limitations. In this study, 2 surgeons performed all the procedures. The prospective data collection sheets were what was done prospectively, and EMR notes were reviewed. And primary outcomes were the assessment of safety and management of complications. And secondary outcomes were the excessive weight loss results and comorbidity resolution. And the average patient had a BMI between 33 and 79, and they had diabetes, obstructive sleep apnea, hypertension, and arthritis were the most common comorbid conditions this group of patients had. And as you look at the resolution in type 2 diabetes and the excessive weight loss that we had, at 1 year it was 89% excess weight loss, accumulating at 3 years to 77. And the comorbidity resolution, hypertension at 3 years was about 58%, sleep apnea was nearing 100%. Type 2 diabetes was at least 70% at 3 years, with improved resolution at 1 and 2, but dissipated over time. And complications management, this is the most interesting part of this paper to me, because the complications in this large cohort were so small in their experience. They only had 1 episode of bile reflux that required conversion to Roux-en-Y. They had 1 episode of excessive weight loss that resulted in a revision and shortening, some gastrojejunal strictures, and really a low number. The largest was stomal ulcerations. They had no perforations of marginal ulcers reported. And that is what you see over and over again in the literature, low rates of complication, which causes some skepticism among American surgeons. But the body of literature is so vast and so consistent that this really became our experience as well. This is another paper published in 2019. It's 3-year outcomes, concluded total weight loss, malnutrition, and comorbidity remission at 3 years were comparable. Reflux was less frequent after Roux-en-Y. So there's no argument at all that the Roux-en-Y gastric bypass is probably the premier procedure that will virtually eliminate reflux, but it comes at a cost, and it comes at a level of complexity that might benefit most patients to avoid. There were definitely shorter operative times in the OAGB and less frequent episodes of stricture, dumping syndrome, and marginal ulcerations. And so here you see the follow-up data. They got pretty good follow-up over their 3 years, almost approaching 50% in both groups. So follow-up becomes the most difficult problem in these types of papers to maintain believable data as far as complications. The unadjusted and adjusted weight loss, you see very similar results. Total weight loss at 1 year was at 36% in the OAGB, and that stayed consistent with a little peak at 2 years, and very close, somewhat outperforming Roux-Y gastric bypass. And the patient cohort were the same, 288 for the bypass, 324 for the OAGB. When we look at the evaluation of comorbidity resolution, diabetes usually becomes the most important aspect of comorbidities we look at. And we have fairly consistent resolution, the 82% at 1 year in the OAGB group, going down to 71 and then popping back up to 79% at 3 years. And that's very similar in the Roux and Y group as well. The outcomes were 80% at 3 years, 71 at 2 years, and at 1 year was 69%. Sleep apnea has a similar resolution, 81 to 85%. Hypertension is somewhat better treated in the Roux-Y in this cohort, but we reach almost 60% resolution in the OAGB group. So we have favorable, good outcomes and resolution of comorbidities, which form the basis of a good operation. When we look at late complications, malnutrition was below 5% in the OAGB groups. Again, it's going to be a somewhat higher risk of malnutrition in OAGB because of the length of that bypass limb, but very comparable to what you see in Roux-Y. Dumping syndrome was better in the OAGB group than the Roux-Y. Internal hernias are almost non-existent in the OAGB group, and they're quite common. All of us have seen those in the Roux-Y group, and they can be quite devastating. And marginal ulcers, insufficient weight loss, and other were favorably compared between the two groups. So the if-so position statement that I alluded to in the beginning really resulted in over 16,000 patient outcomes being reviewed, which were already published. And they came to the conclusion that in the 2018 review that one anastomosis bypass become a recognized bariatric metabolic procedure. And that's what proceeded with the if-so statement. And we dissolved the idea that this was investigational. This was looked at again by if-so in 2021. And they summarized 9 randomized controlled trials, 17 prospective, 53 retrospective, a large number of papers. And they came to the conclusion in 2021 with respect to bile reflux, it was described, but it was not very common and frequent. And as such, was not something that could be a major criticism of this procedure. And further qualitative studies really needed to be done. Major perioperative complications were in the 2 to 3%. Most of them were returning to the operating room or prolonged length of stays and blood transfusion. And mortality was extremely low at 0.5%. And the final conclusion was OAGB appears extremely effective in reducing comorbidities, offers a good quality of life with an acceptable complication rate. Now, nutritional problems have been discussed largely because of the Omega conclusions. And while the data is currently lacking, there's one paper that suggests long-term nutritional deficiencies are not really reported as a problem in most of the papers that are out there, and they're easily treated, usually resulting in a shortened common channel, which can be lengthened. So that's the importance of measuring to be sure that your total limb length will give you a common channel of at least 400 centimeters, because some patients do have shortened bowel. If you don't pay attention to that, you can end up with nutritional deficiencies. We've not experienced any nutritional deficiencies that require intervention yet in our series. And is bile reflux something that has been over discussed? Well, Dr. Genko in Italy produced a paper in 2021 that looked at bile reflux among all of the procedures that we do. And he wanted to evaluate the long-term effects of reflux and specifically bile reflux. And patients were assessed by endoscopy and symptoms were reported. And when he looked at the results at over 3 years, he concluded that 74% of biliary reflux does occur in the sleeve gastrectomy group, whether symptomatic or not. And the presence of this kind of reflux was higher in patients who underwent sleeve versus those patients that had bypass or OAGB. Barrett's esophagus was not a problem at 3 years, only resulting in one patient who had a sleeve. And the final numbers were that OAGB had about a 70% bile reflux incidence of reflux leaving the jejunum and entering the gastric pouch versus 75% in the sleeve gastrectomy group. So this is something that we're already treating and comfortable with in sleeve, and it's really something that is not a major problem in our experience in the OAGB. However, if it does turn up and patients cannot tolerate bile reflux that makes it to the esophagus, they will have symptoms that will not let them leave your office. And it's relatively easy to monitor, and it's relatively easy to repair. You really have two choices. The upper illustration shows how you simply transept the afferent limb and can convert to a roux if that's what you're comfortable with. We tend to use the bronchoenterostomy when it occurs. We see this more commonly in patients that have had a band, but it's rather easy and you get instant relief. So, weight regain, it's very easy to convert this back to normal anatomy. It's also very easy to adjust it. You have a long pouch, which gives you the options to convert to traditional roux-Y or simply lengthen the roux limb, the loop, or create a lengthened roux limb, whatever your preference is. So these operations are easy to adjust and give us much more room to work, because here you can see in a patient whose operation was now 1 year old, you can still see the crow's foot. You can see that it sits well below the liver, a very easy workspace, free of adhesions to address any problem. So in summary, it's easy to teach. The outcomes appear to be outstanding. As you get better and better at this, you'll experience the same sort of experience we had. If you listen to the surgeons that have done this and follow their advice, you will not repeat the learning curve. The results usually exceed the current operations that we're doing. And with respect to roux-Y gastric bypass, it's clearly easier, eliminates the risk of internal hernia to close to zero. There's no risk of intussusception with this operation. And it can adapt to same-day surgery quite nicely, which will eventually decrease the access to care costs and maybe allow us to improve the availability of bariatric surgery. The OR time is short, and the final conclusions that I want to leave you with today is the ease with which this operation can be performed, provided you follow what we have already learned. It can be standardized so that everybody can be really describing the same operation. Bile reflux is real. We're not going to say it's not, but it's relatively easy to treat and easy to monitor. And ischemia, strictures, ulcers, while they do occur, the pouch itself is better perfused, and there's almost no interruption in blood supply, so we should not see ischemia being the problem. And that's where I'll leave you with today. I hope that was useful, and thank you for the invitation to participate with this.
That was very useful. Thank you so much, Dr. Billy. We will move to Dr. Rodriguez, who is going to talk with us about Roux-Y gastric bypass.
Thank you, Kunoor, and thank you, Shaina, for the invitation. It's always a great honor to participate in these sessions, and I also applaud the ASMBS initiative to run these fellow-centered webinars. So we're going to switch gear a little bit and actually talk a bit about a more traditional operation, which is a standard Roux-Y gastric bypass. I have no financially relevant disclosures for this talk, so you'll see products from different companies in my videos, but none of them are really relevant for the talk. So what we're going to talk about is we're going to touch a bit about the history. We're going to look at a lot of technical variations, look at outcomes, and also talk briefly about some complications. So I always like to talk about history, especially for this topic, because I feel that as a surgeon, not just as a bariatric surgeon, the term Roux-Y has become a synonym of bariatric surgery. And I think it's always easy to forget that the term Roux-Y is something that was really described for reconstruction of the GI tract. So you can really plug a roux limb into anything. And that's really where the term roux comes from the surgeon Cesar Roux, who described it in 1893. And when you plug that into bariatric surgery, it's interesting how history repeats itself. And back to Helmuth's talk, the initial description of gastric bypass for weight loss was actually done with a loop configuration in the 1960s, when Mason and Ito described the first paper on gastric bypass for weight loss. And it was until a few years later, because of some similar complications, mainly bile reflux, that a different group of surgeons recommended converting to a Roux-Y configuration for gastric bypass for weight loss. And in 1994, it was when we saw the first description of a laparoscopic approach by Whitgrove and Clark. So I think the history behind Roux-Y gastric bypass is quite rich, and it's interesting to see how things are kind of, falling back into a circle. In bypass, no doubt that it has lost a lot of the popularity over the last 10 years. This is a paper that was published last year, actually, looking at the incidence of gastric bypass by different IFSO chapters. And you can see how the popularity has really decreased significantly. But I think there's still a lot of practice patterns in different parts of the world, mainly in Latin America, where bypass continues to be a fairly dominant operation. And I think that the result of this in the US specifically is that we have seen a lot of the anastomotic cases for fellows decrease, which is really a challenge when you're training and when you're in that kind of rich part of your career and you're learning specific techniques that you're going to carry on and evolve when you go into practice. So I do think that one of the biggest disadvantages of gastric bypass falling out of favor is the training aspect that we're losing in terms of fellows becoming highly proficient at doing anastomosis and then adapting to other anastomotic techniques as well. So when we talk about technique, I like to think of things in two different aspects. So one is the surgical conduct and planning. So how are you going to advance through the operation? And the things that we always talk about are the pouch. How are you going to construct your pouch? What are going to be your reference points? Are you going to calibrate? Because we always read about the 30 ml pouch, but it's really difficult to calculate volume based on either anatomic landmarks or a calibration tube. What limb lengths are you going to use? There's a lot of variation in the literature and in different practices about the lengths of the limbs. How are you going to perform the steps? Are you going to start with the pouch first? Or are you going to start with the JJ first? And I think these are important decisions to make ahead of time. And are you going to do a leak test? Are you going to use endoscopy? Are you going to use methylene blue? And you know, prepare your team for these things. And then when we look at specific technical aspects, we're looking about how to construct the pouch, how do you approach the pouch, how do you perform your anastomosis, both the JJ and the GJ, and how do you close your defect. So what I'm going to do next is show you a couple of things, but you know, I think that this is probably one of the operations that we perform in the entire realm of general surgery that has the highest variations. And one of the things that I've really enjoyed about this new chapter in my career is that I work with surgeons who have trained in different parts of the world. So I work with, you know, European surgeons, Asian surgeons, American surgeons, and everybody does it differently. And I can tell you that just in the last year, I have evolved and changed my technique just from watching other people do it. So my way is not necessarily better, but this is kind of how I do it now. So this is my setup. I usually use my right hand for the 12 millimeter instruments, camera in the left paramedian space, assistant trocar in the left upper quadrant, and my left hand in the right upper quadrant. And I always use a liver retractor. So the first thing is the pouch. I think, you know, I usually go by anatomic landmarks, and you can see here two different ways of doing the pouch. On the left, we're using energy to divide the perigastric tissue in a descending branch of the left gastric. And on the right, we're using reinforced stapler. You can also do a perigastric approach. I usually don't do it, especially in high BMI patients. I just think it takes more time and you can sometimes run into bleeding. And then two different techniques. So this is the kind of classic way that it was described, where you did your pouch already. Now you're going to go find ligament of Treitz. You're going to measure your biliopancreatic limb, divide the jejunum, divide the mesentery to avoid tension on your anastomosis. I think early on in my career, and I still tell my fellows that, mark your roux limb, because you always want to avoid the most feared complication, which is a roux and O. I have my assistant hold the biliopancreatic limb. I run the roux limb, and then I do a side-to-side jejunostomy using two-stage sutures to hold the bowel in place, using a single fire of a 60 millimeter GIA stapler. I know some people like using 45s. That always makes me a little bit nervous in terms of potential obstruction, especially if you get a hematoma or something. Here you can see the enterotomies, and then using a low height load to create the anastomosis, and I use a hand sewn technique to close the common enterotomy. Some people like to do a double stapled, which, you know, takes less time, but I think also I always fear about narrowing my transition with this technique. Running the bowel again, closing the mesenteric defect with non-absorbable suture. You can do this from the top down, like I'm showing in this video, or you can go from the bottom up. I like this video that, you know, the most common thing that happens is getting too deep of a bite and ending up in some bleeding. I'm gonna skip to the next video because I'm gonna talk a bit about the anastomosis later. This is a totally different technique in which the pouch was already done, and this has been referred to as the simplified technique, which was popularized by the Brazilian crew, where you basically create your pouch and then keep a loop configuration. And you construct your gastrojejunostomy first. You bring up that loop, which helps you kind of decide where you're going to have tension or not. I'm using a linear technique in this video to construct my gastrojejunostomy, as you can see here, and using a V-log to close the common enterotomy of the gastrojejunostomy. And I like about this, especially depending on the type of assistance that you have, that you can change a lot of these things depending whether you have reliable, good help, or you're basically kind of, dealing with whoever's helping you in the OR. I think when you're in fellowship, you always have the luxury of a perfect setup, and usually you're the one variation in the room. But once you go into practice, it's the other way around. So you're going to have, you're going to be the only constant in the room, and the variation is going to be who's going to be helping you that day, especially if you go into community practice, private practice, where you're not going to have necessarily another trained person helping you. So after the GJ, you create a window in the mesentery. You're going to divide that loop configuration. So on the screen right, it's going to be your biliopancreatic limb. And on the screen left, it's your root limb or your elementary limb. You're going to measure that after transection, and then you keep everything in the left upper quadrant. Here we're doing the side-to-side jejunostomy, again using a 60 millimeter load, and then using the similar technique to close the common enterotomy and then closing the mesenteric defects. So in the interest of time, I'm just going to fast forward this video a little bit. Here you can see the closure of the mesenteric defect in a different technique. So now we're going from the apex up. In the prior video, we went from the top down. And then in terms of the anastomosis, so in the top left of the screen, you guys saw this already. So basically a linear staple anastomosis. I'm going to skip to the next one, which is actually using the Orville device to complete a circular anastomosis, which is very technically easy to do. I think it's probably the easiest of the three techniques. It does require a little bit of an assistant that knows what they're doing, because they're going to be manipulating the stapler and the valve for the most part. So you can see here using a 25 millimeter Orville device, inserting the EEA in the left upper quadrant and opening up the tip of the candy cane, and then amputating that tip of the candy cane, which is usually enough. I like to reinforce the anastomosis by placing just 2 corner stitches and a couple of lamberts anteriorly to decrease the tension. And then on the third video, you're going to see a hand sewn technique, which I'm going to use here the 2-layered hand sewn. You can do this in 1.5 layers or even single layer, but it's a little bit more challenging to perform in 1 layer, because you need to secure the valve before you start making your enterotomy. So you can see here we did a posterior layer. I like to start with 2 stitches in the middle of the posterior row, and then I run each one away from me. So on the upper part, I do the canal technique in the corners, because I do like the way that the canal suture imbricates the corners and decreases the tension in your weakest point, which is going to be your corners here. So it's I always remember one of my former mentors when I was a resident, you used to always use the analogy of the bar, right? So you go in the bar, out the bar, and then you cross the street. So here we're doing the second layer of the anastomosis, and then I always use endoscopy at the end to do my leak test, check for bleeding, and I can't tell you the amount of times that an endoscopy has saved me from a take-back, either from a small leak that I didn't recognize and I was able to repair, or just from some bleeding. So changing gears a little bit, talking about outcomes, I think one of the biggest things in the last few years is that we have seen increasing level 1 evidence to support gastric bypass as a very effective operation, as well as SAVE. And this is data from 2 of the most commonly cited trials, which is the SLEEF pass and the ASMBS. So as you can see, both of them use similar techniques for their bypass, so a 50 to 80 centimeter biliopancreatic limb with longer elementary limbs, and that has changed a little bit in the last few years. In the sleeve pass, 57% excess weight loss at 5 years, 25% of diabetes remission, 60% of patients who have hyperlipidemia were off meds, and 5% were able to decrease the dosing of their medications. Of the ones who had hypertension, half of them came off their medications at 5 years. Similar results for the ASMBS, so 68% excess weight loss at 5 years. Diabetes remission in this group was significantly higher, but the criteria was not as well defined. So it is probably one of the outliers in terms of the effectiveness of diabetes control. If you look at other specific studies like the Stampede trial, it does hover around 30% at 5 years for a complete remission. Hyperlipidemia, similar to the sleeve pass, 62% of medications. And the ASMBS actually talked about reflux, so 60% resolution of gastroesophageal reflux disease in these patients. And I think that this is probably one of the practice changing decision makers in procedure selection is reflux. And to this day in my practice, patients who have significant reflux, I think a bypass is still going to be the best operation. In Nguyen's trial, again, looking at 5 years, improvement in remission of diabetes in the vast majority of the patients, hypertension close to 80%, and dyslipidemia a little bit over 70%. In terms of complications, so we always talk about early and late complications. I think the early complications, leaks have significantly decreased over the last 10 years. So currently we're talking about 1.6 to 2% of leaks. Bleeding, 2%. You know, we have to remember this is one of the operations where you have multiple potential bleeding sites, both intraluminally and extraluminally. Bowel obstruction, 1%. BTEs, 0.1%. Wound complications under 1%. And some of the later complications that we worry about, such as marginal ulcers, strictures, obstructions, internal hernias, are quite rare, not that common. So I think the safety and the durability of this operation has really been supported by a lot of existing data. So in summary, I think that Roux-en-Y is not dead. It's still a very popular operation. And I think that it's probably going to make a little bit of a comeback as some of the more kind of newer data on sleeve comes out. It's one of the operations where experience matters. And usually the learning curve in some studies is around 100 cases to really become proficient at doing a gastric bypass. The metabolic outcomes in most of the trials that have compared them are superior to sleeve gastrectomy, even though weight loss is quite similar. And the safety profile, without a doubt, is quite excellent. So thank you again. And I look forward to a discussion now.
Thank you so much. That was fantastic. Thank you both again for being here and for these phenomenal lectures. I am going to turn it over to my partner in crime and surgeon extraordinaire, Dr. Shaina Eckhouse, who will lead our question and answer session.
Thank you guys for those, both of those very engaging and interesting presentations. I'm going to start with the questions that we got in our chat. The first question was a clarifying question to Dr. Billy. If you can kind of actually define what you meant by crow's feet. I think there's some confusion on that anatomical landmark on the stomach. I don't know if you would be able to just talk through that real quickly.
Sure. Maybe it reflects on my age because the old gastric anatomy that we were taught, you know, there really were three landmarks. One was the lower esophageal gastric junction at the hiatus. The second was a collection of vessels on the lesser curve where the lesser curve blood supply seems to coalesce into 3 to 4, even 5 vessels that is quite distinct right at the angularis incisura, which we refer to as the crow's foot. It's on the lesser curve where the blood supply seems to end. And then there's a good 3 to 4 centimeters between that vascular landmark and the pylorus. And you're trying to do your dissection between that landmark that we call the crow's foot or the collection of vessels on the lesser curve at the angularis and the pylorus. As you do bypass and sleeve and other procedures, you want to get really good at identifying those anatomic landmarks so that you can recognize them, because they become more difficult to recognize when you're doing revisions of sleeves, since the procedure's already been done and there's some changes due to the effects of previous surgery.
Thank you. Going back to the chat, there was another question. How do you measure the smile bowel for the OAGB? Since you said that you want a 200 centimeter afferent limb and a 400 centimeter common channel. If you cannot get a 400 centimeter common channel, what do you do?
So this is the ultimate question, is how do you measure? I think each surgeon has to pick their own way and stay consistent. The instruments that we used, if you come to our OR, you're going to see these graspers over and over again, which have 5, 10, and 15 centimeter markings on them. So we can accurately and reproducibly measure the same way. So the way I measure appears to be 200 centimeters. The way John measures appears to be 200 centimeters in his hands, or 400, or however we measure. It's important to develop your own consistent way. It could be with an umbilical tape. It could be with different instruments. The point is to stay consistent. Now, it's very important before you do the anastomosis. So we connect with a posterior row of sutures to create where the anastomosis will be. It's that point where you have not reached a point of no return that you measure and see that you have at least 400 centimeters. I just stopped counting when I hit 400, because it may be 500, it may be 700. Once I hit 400, I'm quite reassured that I have enough length. In the event that it came to like 310, I would remeasure it again. And in that case, I would adjust my afferent limb down, maybe even as little as 100 centimeters, to be able to reach those nutritional goals that I have a common channel with absorption. In my hands, I like 400 centimeters. All the papers, and there's very few that have been written on malnutrition after the OAGB, show a demonstrated common channel that is in the 350 or less range when those authors had problems in their own series.
Thank you. You know, considering, I think, Dr. Bill, you mentioned this is the ultimate question. I 100% agree. I think about what are our limb lengths for any of the procedures, and have we figured it out or gotten it right? So I'd be curious, Dr. Rodriguez, how do you measure bowel for the bypass? Or other procedures as well?
I think that that's really, like you guys said, it's really challenging, because part of the problem with the bowel is that being, you know, so soft and malleable, you can take 5 centimeters of bowel on an umbilical tape and stretch it to 10 if you pull on it hard enough. But I like to use marked graspers, and I try to avoid over tension on the bowel. But again, I think, you know, sometimes you go back in a case, even one that you did yourself, and you count the whole bowel, and your measurements may be off. So I think we do the best we can, and I like to use marked graspers. That's kind of how I like to do it.
I have a question. I think this is for maybe everybody here. We are lucky in North Carolina, so we now have insurance coverage for one anastomosis gastric bypass. And so I'm going to start, I think, yes, Shaina, yes. But when I think about the scenario in which I choose this, what I struggle with is, when am I going to offer SADI and when am I going to offer one anastomosis gastric bypass? I would love to get your thoughts on this one by one. So we'll start with you, John.
So, you know, I love this talk, and I love every time Helmuth is speaking somewhere, I try to be there, because he's somebody that I respect, and I can see the way he presents his data and the data that's available. But I have always been very biased because of my practice. So in the US, my only experience was with complications, and then I come here to the Middle East, where one anastomosis gastric bypass is very popular, and there are so many technical variations, and I can't tell you the amount of times that I do an upper endoscopy in a patient with a bypass, and the pouches are all over the place.
Yeah.
So I know that there's some technical challenges with that, and for that reason, I never looked at adapting into my practice. While I did with SADI, and I'm quite comfortable with SADI, but I am seeing now patients asking for mini bypass here. So I do think that it's something I'm going to start adapting. but also using patients as part of the selection process, because sometimes patients do their own investigation. They come to you and they know what they want, and it's very difficult to talk them out of it. But I do think so far I have favored SATI over one anastomosis gastric bypass, but I am clear there's a big bias in my practice.
And I got all my experience in SATI and in OAGB from having a commuting practice to the Middle East, where I got to experience this without the worry of insurance or even consequences, because 7 years ago, when I was doing my first SATIs, not many people were. I may have been the only guy in California. And so as it evolved, what I've learned with SATI is that there is a consequence of malnutrition that has seemed to have gone under the wire. I'm now learning I've revised 4 SATIs for the kind of eye-opening malnutrition, edema, terrible protein levels. I don't have an explanation because I'm doing it exactly as I was taught, and it doesn't seem to be consistent in all patients. So you sort of learn who you want to take the risk with a more aggressive operation. And I'm biased to using SATI more preferentially in the BMIs that are over 55 and over 60. I feel safe and comfortable with that. When I get a BMI in the 40s, but I may not trust the patient to do well, or I worry she's going to learn how to eat around a bypass. And this is the art of surgery. You learn to see in the patient population you are treating what is going to work. I had a different patient population in the Middle East. They ate differently than the patients out in California eat. And I'm sure they eat differently in North Carolina because of the collection of cultures that we have across the country. It seems that the OAGB is going to fit in to those patients that I don't want to take the risk of a 250 or 300 centimeter common channel, which is what we're commonly doing with a SATI. And it just comes down to my biases. The OAGB for everyone is going to be easy to ignore in the US because it's new. You're going to have to get your 100 patient experience, that is the John Rodriguez experience or the Helmuth Billy experience, or any of us are going to get comfortable with how it turns out in our hands. So I live in a border state with our colleagues in Latin America, and sometimes we in the United States will be very critical of how a sleeve turned out across the border, yet we don't stop doing sleeves in the United States. And it's going to be similar with this procedure. If it's done in other areas or by other surgeons, we're not going to stop what we do if we feel we get good results, because this is really a technique that varies across our hands. We have not standardized any procedures yet. So the outcomes become individualized.
That's a great point.
So as somebody who struggles to get, how do you adapt these the single anastomosis bypasses, either the OAGB or the SATI, in a state that's not necessarily, from an insurance perspective, favorable?
So our experience was we had very nice success with revising sleeves to whatever we wanted. Revision seemed to be the one area that you can utilize that. You do have to talk to medical directors. You do have to justify why are you going to stop at a loop anastomosis instead of doing a roux configuration for a DS. But this is the labor-intensive part of bringing new procedures into areas where insurances are restrictive. You have to talk to your medical directors. And if you look at the history of why North Carolina has that approval now, it's because of one group that collected their data and spoke to insurance companies over the last 10 years and successfully showed them that this is a procedure North Carolina should be offering. There's a lot to learn from the North Carolina history on how they did that, on how we can get this adapted across the states. But it's challenging, and it starts with the revision operations. That's where you're going to have the easiest access to your patient population.
I have another question. And Shaina, unless you have a question. Okay.
Go for it.
I think one thing that I really want the fellows to take away from this is, what is the major long-term complication, the Achilles heel of your operation, and what are the prophylactic things you can do? So for me, for instance, John, for a room-wide gastric bypass, I know once a month I'm going to get a call that there's going to be a perforated ulcer. in my ER, marginal ulcer, internal hernia, whatever you think the worst long-term complication is. What are the things that you do at the time of the initial operation to keep that from happening?
I think the first thing, which really ties up to everything that we do, is patient selection, right? So, you don't want to be offering bypasses on patients that have high risk factors for all these complications, right? Patients who have histories of non-compliance,
Yeah.
They're not going to be taking their post-operative vitamin supplementations. Patients who are smokers, patients who are on chronic NSAIDs, that's a recipe for disaster, because those are the ones that are going to show up with a non-healing ulcer, a few weeks after your operation. I think that that's really probably the most important thing when you are seeing patients, is really selecting patients properly. And I'm sure that if you're going to be doing something new, like Helmuth was mentioning, it's even more important, right? So you want to really make sure that you're the first time doing this, or your first couple, are going to be on well-selected patients. And I think that it's surprising to me, honestly, without criticizing anybody in specific, because I was part of that as well at some point, is that you have to learn with time how to adapt to up and coming data. And I think the discussion about closure of mesenteric defects in Roux-en-Y should stop. I mean, there's enough to say, and Helmuth is showing an operation where you could argue about not closing a defect, and he's actually closing the defect in a one anastomosis gastric bypass. So the fact to me that people still don't do it is shocking. And the other thing you have to remember is that if you're going to do it well, because the only thing worse than leaving a space open is a poorly closed space. So technique really matters for these things.
Awesome.
Well, John hits the nail on the head. A lot of our colleagues around the country are very critical of the sleeve gastrectomy. It doesn't work. It's always going to fail. Not positive comments on it. Reflux is a big problem, but there's nothing worse than seeing a smoker who tells you he's quit, and he quit 8 weeks ago. I mean, he's still a smoker. The likelihood of smoking is going to come back. Or the patient that's taking 800 milligrams of ibuprofen that she purchases and doses herself for whatever ailment. I mean, we're seeing high dose, high risk behaviors. And for me, the sleeve really shows me who's going to need more surgery in the future by their outcome, because not all of them are going to fail. Maybe 50, let's say 60% fail. That's 40% that don't need any more surgery. And it also shows me that I can develop a relationship with my patients on understanding who is going to abuse ibuprofen. So now when they need a revision, I have 3 choices. I can easily revise a sleeve to a standard Roux, and I've done that many times. I can revise them to an OAGB, and I can revise them to a SADI. And I can tailor it to what that patient's behavior categorizes them into as far as risk factors. So I like the sleeve in selected patients. The patient who's nervous, how many of us have seen patients who are nervous about having their anatomy rearranged? Well, they're going to put their big toe in the pool, and they're going to have a sleeve. And all that we really have to pay attention to is reflux a problem. And we're going to have more tools for reflux. We're going to have magnetic sphincter augmentation devices that we're all comfortable with. We're going to know that we can revise and fix a hiatal hernia with more tools than just simply closing the defect. We're going to perfect how to use a modified Hill stitch. We're evolving on how to use these operations that really tailor themselves around the behaviors of our patients to give them the best outcome, and rather than just a knee-jerk, failed weight loss after sleeve gastrectomy, Roux-en-Y gastric bypass. It's not that simple. And if it was that simple, we wouldn't have fellowships, and we wouldn't have a lot of good mentors to teach us how to utilize these for the best results in each patient we face.
And I love that you're talking about obesity as a chronic disease and weight recurrence being a real issue. I think this is something, especially for our fellows now, we're going to be dealing with this lifelong with our patients. And, they're not necessarily doing anything wrong or they often feel like they're at fault for this. And so I think us as surgeons talking about this disease process this way is really important for them. I'll get off my soapbox on that.
Well, but you're absolutely right. I mean, the first thing we tell a patient when they're choosing a sleeve, if you regain weight, don't beat yourself up. It's the limitation of the operation. if we see a bypass that regained all their weight and their BMI is 49, we reverse them and usually change them to a single anastomosis duodenal switch. But we picked the wrong operation at the outset. We don't have enough time to know everything about our patients. And in the past, we didn't have a lot of choices. When I started, it was Roux-en-Y gastric bypass. That was our choice. And then the lap band came along. Well, more patients had lap bands than had Roux-en-Ys in our practices, but now we're having to move them along. And so it's really exciting time in obesity surgery because we have so many tools. And the common question of how do we pick one operation for one specific patient? Well, that's the art of being a surgeon. Yeah. And if it was easy, then we would just be saying one operation, but they fail, and they don't necessarily fail solely because of the patient. They fail because of culture, they fail because of environment. I mean, we have a saying in our practice, don't eat with your fingers. Well, John, I can't tell a Middle Eastern family not to eat food with their fingers. The standard traditional meal is sit down and eat with your fingers. So the culture is going to have us evolve better behaviors and as we learn on how to take care of our patients. You know, so it's, to me, the saddest thing in my career is that, you know, I'm going to be 60 in a couple of years. And last time I looked, I was the age of these young surgeons at Duke. And you're going to have a very exciting, and I'll be watching from the sidelines, wondering who's going to help me up out of my chair.
You're going to be operating until you're 80, Helmuth. We all know it. I think we're at time here. Thank you both so much. That was a really, really well done set of lectures. I am so glad that our fellows have you to learn from and appreciate your time. We will be having a question and answer session for the West Coast after we re-air this afternoon. So we will see you again later.
Thank you all very much. And don't forget about ASMBS weekend in November.
See you all there. Good seeing you, John. Take care out there.
Yeah, you too.
Great. Thank you, guys. Thank you so much to Dr. Bailey and Dr. Rodriguez. Those talks were incredible. I feel like I always learn so much from the fellow project whenever we have these experts come in and talk to us. So we're very appreciative of you taking the time. I would like to start off with a question about OAGB to Dr. Bailey. It's, you know, I think traditionally the bypass has been considered as a salvage operation for patients who've undergone previous bariatric surgery. Do you see the OAGB as being that type of an operation? Do you think it will eventually supplant the Roux-en-Y?
Yes, and thank you again for the opportunity. The OAGB is one of those operations that we have not utilized in very large numbers or at very many practices in the U.S. And we initiated it about 5 years ago, and we used it as a salvage operation primarily for sleeves, because we were trying to stay within the guidelines of the MBSA QIP and using it only for revisions. We were able to start doing some primary operations, but I think that in the US, it's going to start first with revisions because that's what we're comfortable with, and we don't have to deal with insurance blocks when we're revising somebody. What you're going to find is that after doing this for 4 or 5 years, it's actually very challenging to find a patient that you wouldn't prefer the OAGB as your go-to operation in most cases. Obviously, patients with BMIs of 60, I'm still partial and biased towards SADI. I still like the Roux-en-Y. It was the primary operation I learned how to do back in 1999 and 2020. But I think that if I can be changed to where I like it as much as I do, then the curiosity of everyone out there, and particularly the fellows, is going to be raised. And we will start to see practices that are primary OAGB practices because the outcomes that individual surgeons get is very reproducible.
Thank you, Dr. Billy. Well, I just want to again say thank you for joining us. It was truly an amazing talk, and I personally enjoyed it. And I know the fellows, I'm sure, learned a lot from some of those videos because it's not a procedure that we perform on a regular basis. So again, thank you. We have a question from one of the fellows talking about the selection of your patients. When you see a patient following a sleeve with weight gain, how do you decide? You mentioned SADI versus one anastomosis gastric bypass. How do you decide who gets a SADI and who gets in one anastomosis gastric bypass or even a gastric bypass?
So I'll be honest, the gastric bypass option has fallen to my third choice. So very few get gastric bypass, with the exception that they fall in a BMI of the 40 to 50 range, and I'm concerned about the amount of reflux they have. There's no question that a RU limb is the best treatment if you're only talking about eliminating reflux. We have a lot of patients who've had previous lap bands. And there was recently a paper published out of Australia about OAGB. And I think 60% of the patients that had lap bands, and they noted a high reflux rate after the OAGB. That's been our experience as well. Lap band patients are unreliably good candidates to have an OAGB because the reflux is 50-50. And so if I have a 50% chance of having to address reflux afterwards, I'll probably go towards a standard Roux-en-Y gastric bypass because it's very predictable that a lap band has dysfunctional LES features that will contribute to reflux at a higher rate with a loop configuration than you would get with a Roux reconstruction. So that's one factor. The other is I'm still biased with BMIs over 55 and 60 that they'll just do better with a duodenal switch SADE configuration. So if somebody has regained their BMI that high after a sleeve, I think it's perfectly posed to do a SADE, and I'm going to get a more predictable result. And I'm only 4 to 5 years ahead of the average practice in the United States. So these are what I've developed as far as my choices. Now, if they have reflux, and that's the main problem, we have found, counter to what everyone's instincts will tell them, that the OAGB is a good anti-reflux operation if you make it a long pouch, if you stay below the crow's foot anatomic boundary there and have a 12 to 15 centimeter gastric tube. You don't see a problem with reflux, but each individual practitioner is going to have to see that for themselves before they actually believe it. So Roux will stay on in reflux patients more commonly than just weight regain patients.
So basically, even like the patients who have heartburn, esophagitis, issues, maybe bile reflux, you would still do one anastomosis gastric bypass. And your experience is, from a heartburn standpoint, those patients are doing well long term.
Yes, unless they've had a lap band. The lap band does cause pause for concern because there was some damage there. We have not seen a reason to move away from OAGB in a sleeve patient who has significant reflux or even bile reflux. We endoscope all the patients before surgery, and we have not automatically said, oh, bile reflux after sleeve, you can't have an OAGB. We've seen the opposite, that they do just fine. And the part about the OAGB is that the weight loss is extremely predictable, and we have yet to see it be worse than what we would expect with a Roux-en-Y, which is why it's slowly becoming our favorite operation.
Okay, very good.
You mentioned earlier in the talk, Dr. Billy, and I'm sorry, Dr. Rodriguez, we'll get to you. You mentioned earlier in the talk that there were issues with getting insurance coverage for OAGB. Is that still the case now? And if not, how are you getting around billing and coding?
Well, things have changed. We certainly saw that there was a large volume group in North Carolina that successfully worked on their own to convince Blue Cross and some other payers to eliminate the exclusion for OAGB. So we will be doing some work at the level of the ASMBS to approach those same payers who are regionally not involved with North Carolina. So I hope to have some good news by the end of 2023 that we've made some progress. Interestingly, earlier today, I was on reading our Medicare guidelines, which used to have the procedure excluded by name, but is no longer excluded, at least in our Medicare region. The only excluded procedures were open bands, procedures that involved intestinal bypass where it was pure, like a jejunal ileal bypass. I think the list was 3 or 4 procedures, but OAGB, mini bypass, the Rutledge procedure, those were no longer on the list of exclusions. And so in the next few months, we'll be looking and testing which codes are appropriate under the approved codes that these payers will pay for. Rather than coming out and just suggesting codes, I'd like to see, if I give a talk, that the codes actually worked and there wasn't a problem with the codes. But it seems that some payers do not have it excluded by name anymore. And certainly Medicare in our region was one of those. We've been successful calling payers directly when they don't, the medical directors of the payers in our regions, and saying, this is what we would like to do. And we have found surprisingly little resistance from our Medicaid HMOs that are managed regionally. and locally, that they let us go ahead and do that. So honesty with your payers, honesty with your medical directors is the first place to start.
Dr. Rodriguez, I have a question for you. I know your practice is not based out of Abu Dhabi, and the culture may be different. Patients may be biased toward the Roux-en-Y gastric bypass because it's not a commonly performed procedure in this part of the world. When you see a patient and you're not doing a sleeve, you're thinking maybe mini gastric bypass, one anastomosis gastric bypass versus Roux-en-Y gastric bypass. Can you take us through the process of how do you approach those patients? Is your decision based on what the patient is looking for, or maybe you base your decision on your endoscopy findings, esophagitis, a large hernia, heartburn, stuff like that? How do you select your patients, mini gastric bypass versus Roux-en-Y gastric bypass?
So, thank you, Maher, and thank you, Julie, for the opportunity to be here. So, I think that's a very interesting discussion because my favorite thing about specifically this fellow webinar is that I've learned so much from Helmuth talk. And I'm in a part of the world where one anastomosis gastric bypass is, the hot thing. And in full disclosure, we're not offering OAGB at Cleveland Clinic Abu Dhabi. And it has been a little bit of a practice bias for really no good reason, because, as a referral center, I think we've been seeing for the last 5-7 years, at least here in the region, a lot of the complications from the Middle East come to CCAD for treatment. So we've been, naturally biased against the procedure. But, the one thing, as Helmuth described in his talk, is that there's a very specific way to do it. And there's a very, well-described technique from 2 different large volume centers that really tell you how to do it. And it's not the common finding when we do endoscopy. So we're in the process of starting to offer OAGB, and we're probably going to be doing so early next year. So it's not one of the operations that we commonly discuss. So we're doing, sleeve, bypass, and SATI, both primary and revisional. So I think that here, same as the US, I think patients do a lot of investigation, and most of them come knowing what they want. And it may not be for the right reason. And when there's a good contraindication, for example, to do a sleeve gastrectomy, which is still the most popular procedure even here, about 60% of our primary cases are sleeves. Reflux to me continues to be a contraindication to sleeve. And if I have a patient that I have to do an entire reflux study to justify doing a sleeve, in my mind, I think it's a little bit of a waste of time. So I'm very aggressive about talking reflux patients out of a sleeve gastrectomy, and I use the same criteria for a SATI. So, SATI has that sleeve component. So I think if you have a contraindication because of the reflux, and bypass is still the way to go. And, hearing Helmuth talk about his experience with reflux patients and one anastomosis gastric bypass, I think it's interesting because I didn't really think of it as a good operation to do in patients who have acid reflux. So I would love to learn more about that. So I think still reflux is number one. Metabolic disease, mainly diabetes. I think still the data in our practice supports doing metabolic procedures such as gastric bypass or SATI, or in the future, one anastomosis gastric bypass in patients who are type 2 diabetics, especially those that have more moderate to severe disease.
And we're learning a lot about our own experiences. These multiple practices, everybody here has fixed hiatal hernias. Yet now the discussion is maybe we can learn something from the old Hill posterior gastropexy. Maybe there's a modified version of that. And we're very aggressive with doing that on anyone who's had a sleeve, or anybody who we're planning to do an OAGB who has any reflux. And, the preliminary anecdotal results is that we're happy with what we're seeing, and we're not having problems with reflux, but we're collecting all of our data prospectively, and hopefully we'll have enough time to present a series that we've put together. But I think there's a lot we have to learn about reflux that we now have the ability to introduce into our patients.
Dr. Billy, two technical questions to follow up on what John was talking about in terms of some of those complications that they're seeing following a one anastomosis gastric bypass, and two things that you actually touched upon in your talk. The first one is the fact that you run the common channel to make sure you have at least like 400 centimeters. So the first question I have for you, do you actually run the common channel before you do it your 200 centimeter afferent limb, or you do the anastomosis and then you make sure you have 400 centimeter? And as a follow-up question, if you don't have enough small bowel, then what? Do you convert and do a bypass or do something different? The second question has to do with the crow's foot, and you mentioned that more than once, saying make sure you stay maybe a centimeter or two below that to make your pouch and come around that a lesser curve and make your pouch. What do you think happens if you don't do that? Is that part of why there is a high incidence or at least a reported incidence of post-op heartburn and bile reflux following one anastomosis gastric bypass? Does it have to do with the length of the gastric pouch?
Yes, it absolutely does. And I'll answer the first question on the limb counting. So what I've learned over 5 years of doing this, how I do it now is I measure out my 200. I then do the posterior row suture to approximate it to the distal pouch. And then I take the time to measure to get to 400 and see that the common channel of the efferent limb has plenty of bowel. If I find that it's short, say it's 350 or 150, I really have all my options available. I could do a sleeve, I could abandon, I could do a Roux-Y, I could feel I need to consent the patient, but what I won't do is do an OAGB with a common length of less than 400 centimeters. I think that has kept us out of malnutrition problems. I have seen malnourished patients, and each one I've operated on that I inherited had a common channel limb of under 300. So there is a tie with that we don't know. And there are some papers, one out of Iran, that did focus on the common channel length when they were doing revisions for malnutrition. So there's something there. With respect to staying above the crow's foot, if you go above it, I have a beautiful video of an upper GI swallow on one of my patients that had a band that I revised to OAGB. It's clearly too short. I'll be showing that upper GI swallow at meetings, followed by their endoscopy. And I've created now a problem that hopefully will be solved by converting him to a Roux limb. But it was a technical problem that I created. I've also watched a lot of surgeons who learned OAGB just like I did by almost see one, do one, teach one. And there's a natural tendency we have to start cheating and getting at the crow's foot or above it because it's easier to fire the stapler. The dissection on below the crow's foot is awkward. You either have to put the stapler high or you have to learn some tricks and techniques that make it a little easier for you to put the stapler there. It's also the thickest part of the antrum. And so there can be bad outcomes with respect to how well your stapler function is. So we have this tendency to cheat. And I've seen that if I get less than 10 centimeters on the tube, I get more reflux complaints. You can even see it on HIDA scans. We've used HIDA scans to show the reflux. And generally in a good OAGB, you're going to see reflux when it occurs into the lower portion of the pouch, but it won't make the esophagus. Start shortening it and you'll see it getting into the esophagus.
So finish that discussion on some of the complications following, and I'm sure we're going to be learning. Obviously there's a bias toward the one anastomosis gastric bypass, at least in this country. So, but the minute we start doing more and more, I think we're going to start learning some of those technical issues that you're mentioning and how to best avoid these issues. But what about marginal ulcers in your practice from doing those patients? I mean, you're still doing an anastomosis between small bowel and a gastric pouch and along a gastric pouch. So I would imagine the number of marginal ulcers that you're seeing in those patients is very similar to the gastric bypass patients.
It's hard to say because we have just thousands of gastric bypasses in our community, and we're only in the mid-hundreds of OAGBs. But I have seen ulcers. We like to believe that because you have biliary pancreatic secretions coming through, that perhaps the acid load is buffered, but I don't have any pH data to show that. Anecdotally, we're not seeing, if you remember the days when you first started doing bypasses, almost all of us would wish that we could make ulcers go away. They were either perforating or they were showing up on endoscopies, but they were a regular member of the party if you were going to get into gastric bypass. That is not anecdotally what I'm seeing in the OAGBs. I have seen perforations. We had one when a woman, I had endoscoped her 2 months before, everything's perfect. 3 months later, she perforates an ulcer. But then she had this weird situation where her mother-in-law moved into her house and she hates her mother-in-law. So she's living under stress and boom, there's a perforation. We do see the ulcers forming with smokers. We do see it with non-steroidals, probably at the same frequency. But the spontaneous ones due to acid are not appearing at the same level when we have no cause for it. And then we just assume it's an acid load. You know, we know how to take care of them. So I sort of look at that as the benefits of the OAGB, even if we have exactly the same ulcer rate, would not be a reason to change it and abandon it because we know how to take care of those things.
So we're actually a little over time, and if you guys don't mind staying on for a little bit longer, because it seems like the discussion is just so great, I do want to give Dr. Rodriguez an opportunity to comment on a technical question that was raised by one of the attendees about the use of the triple staple technique when doing JJs. And also I'm curious to hear your thoughts on how do you decide which of the techniques that you showed us that you're using in a patient, whether the circular versus the linear staple technique or hand sewn when doing a gastric bypass.
Thanks, Julie. So yeah, I mean, I think the triple staple technique, I've seen a lot of people do it. I've never really done it myself. I always worry for some reason I can't really explain about narrowing that transition. But, you know, when I was in Cleveland, a couple of my partners did it routinely and it was, you know, quite fast and effective. I think in terms of what you pick, and I said this in my talk, I think gastric bypass is probably one of the operations where there's the highest variability in terms of how you do it and how everybody does it. And even I can tell you in my practice, if you saw me operate 5 years ago and you see me operate now, it's a totally different technique. And it has to do a lot with who I'm operating with, right? Because when I was in Cleveland, I always had an army of people. You have, you know, your fellow, you have your PA, you have the residents, and you have a system that's always well oiled. So I almost always had two assistants. So I wasn't really thinking about, you know, what I can do myself and what I can have somebody else do because I didn't have that problem. And then I started practicing in one of the community hospitals in Cleveland, and I was mostly by myself. So I moved away from some of the techniques I was doing before. So I found that doing a linear stapler is much easier when you have an assistant that's not familiar with the operation than have your assistant help you operate a circular stapler. So I transitioned my technique to either linear or hand sewn. And obviously there's concerns about wound complications and more pain. So that's one of the disadvantages of the EEA. But now that I'm here, and I don't really have trainees right now, and it's a little bit unpredictable who's going to help me. My technique is totally different. So I just started maybe a couple of months ago doing the Brazilian technique because I can do everything by myself from the right side. I just need somebody really to hold the camera and, you know, maybe help me a little bit with retraction. So I think that to me, that's one of the most challenging things. And it's one of the challenging things that you're going to have to face. And we all went through that when you move from fellow to your attending life, because your next step, your next practice is going to dictate your environment. And I think that's why I think it's so useful and helpful to know more than one way to do things, because you never know when one technique may save you from a problem that you're facing with a different technique. If you only know one way to do things, I think it's a little bit challenging when you're facing a tough situation to get out of it.
Yeah, that's excellent. Thank you. You know, just in the interest of time, I think we'll take that one more question from Dr. Barazinji. I'm sorry if I'm butchering your name. To Dr. Billy, asking about whether or not you would consider doing a 1 anastomosis gastric bypass in a patient with type 1 diabetes.
So the nice thing about the OAGB is you can actually easily reverse it. So I would be very happy to try on a type 1 diabetic to see what kind of stability we can get. There's nothing really well published on the OAGB in that type of patient population. And we can also easily convert it to a RU, which would be what most people would do in the US. Obviously, SATI is an option too. This is an easily reversed operation which preserves those options should that not be the type of treatment that gives the therapy we need.
Thank you, guys. I guess for the sake of time, we're gonna end it here. Thank you so much, Helmuth and John. Amazing lectures, very nice feedback, and thank you for the fellows for joining us.
Thank you very much. It was a pleasure.
Thank you very
I really
much.
enjoyed it.
Thank you, guys.
Yeah.